And I am very happy to see all the things that are going on there. Should I guess, share screen?
Well, we have Professor Germano here to introduce you, so.
Oh, perfect. Hello there.
Hi, how are you? Peter or Chris, I think that Alyssa sent a slide. I don't know if you guys want to put it up or.
I can share it.
Great. Thank you so much, Peter.
Give me 10 seconds.
What is that background there, Emanuela?
That is one of the stock pictures, I'm going to get out of the way, of Boston Medical Center. And it's the green, and then there's the oncology. I feel like a weather reporter. And then there's the oncology program, you know, Moakley there. So, yeah.
Beautiful.
Yeah, very nice. It's nice in the summertime, the wintertime, not so much. To walk in and out of the buildings, but that's okay.
You had it up there for a second, Peter.
I moved it to a different screen and I lost it. Now it's back. All right, I think we have a quorum. Dr. Germano, if you want to take it away.
Oh, sure. I thought that either you or Dr. Bereson were starting, but I'm happy to take it away. Good morning, everybody. My name is Isabel Germano, and it is a pleasure today to be asked to introduce our speaker. I first would like to thank Dr. Peter Morgensen and Christopher Kellner for organizing our grand rounds, and Dr. Srivastava and Betterson for asking me to introduce Emanuela. Dr. Binello probably does not need an introduction for some people in the audience, as she is one of our very successful graduates at the Mount Sinai Neurosurgery department. Emanuela has many, many incredible things, and I'm not going to be able to list them all today. Beside being an incredible surgeon, a very talented person, she is she falls out of the chart for her academic accomplishments, right? So Rui Feng, one of our current residents in neurosurgery, recently published a paper showing that women in the neurosurgery workforce in academia have many more academic titles than men, statistically significant. And clearly Emanuela is at the top of all that. So she has a background in humanities, Russian studies, and then she continues on with 2 different PhDs, and not in humanities, not in medicine, but in nuclear engineering and technology. So I don't think that we can find anyone that is academically as accomplished as Emanuela. Emanuela worked with me in my lab, and since then we have been partners. I've been following her career, and she is really a fundamental faculty member at Boston University. So with that said, Emanuela, thank you so much for sharing with us this hour. We're really very proud of you, and we're very grateful that you're with us today.
Well, thank you so much for that very kind introduction. I'm very happy to connect back to my roots. You know, I have to say, I thought about Mount Sinai a lot, and really, and as I'll be saying in my talk, the things you learn at Sinai and during your residency really are the foundation of everything that follows after that, no question. So let me just, should I just go to share screen now, I guess? No, this will stop others. Can I say yes? Yeah, okay.
Go ahead, I took mine down.
Thank you. Share. Just gonna make it in slideshow mode. Okay, does everyone see the screen?
Gotcha.
All right, so this is, my talk today will really be a little bit about my journey and some words of wisdom that I've learned along the way, and some practical considerations, especially for the graduating resident. So first, I'll just give you a little bit of my own update. This is a picture of Boston right here. And then the second part of the talk will be a little bit more about my some practical considerations for the graduating residency. But before I do that, just a short trip down memory lane. I just couldn't help to resist, just to contextualize my own residency experience. I was a resident between 2006 and 2013. Back then, residents were only at Sinai in the single location of Sinai. We did go to Elmhurst Hospital. We had 3 months of pediatrics at Montefiore with Doctors Goodrich and Abbott at the time. We transitioned from a 6 to 7 year program. We had our very first neurointensivist come when I was around at PGY 2 or 3 with Dr. Frontera. Dr. Post was initially a chairman and transitioned to Dr. Betterson very early on, and also Dr. Betterson, the program director initially was Dr. Betterson, became Dr. Patel. And here is my first class with, these are the 4 of us juniors. This was at Dr. Post's party in 2008. So to my right is Zach George. To my left is Erin Biro. And then next to her is Kenny Delos Reyes. So we were like the core group of junior residents. We all started at the same time because 2 of us were in the 6 year program, 2 of us were in the 7. But this was really, these are the people I carried the pager 2009 with. It's a very, very meaningful relationship. And then below that, I have a picture from my last grand rounds as chief resident, is 2013. I think maybe these faces are a little younger, so that maybe some people still in the audience will know this was Asha and Asha Iyer and Justin Massatelli. They were my PGY 3s when I was a chief. And then this is Jake, who was my co-chief. And here we have Jeremy Steinberger, who was a PGY 2 when I was a chief, and that's Chris Sarkis. So this was a very, very just meaningful core group. These were fantastic junior residents who I was really, really proud to be on the team with. So I think a lot has changed at Sinai since then. It has grown so much, but this was, back in the day, that's where we started from. So I'll first just tell you a little bit about where I am at an academic medical center at the Boston University School of Medicine. It's one of the older medical schools in the country, founded in 1848, and among the first to formally educate female physicians. It has about 1,700 students, of which 700 are MDs, and they're very proud of their role in the elucidation of phenytoin as an anti-epileptic agent. So the Boston Medical Center is a combination of the Boston City Hospital and the BU Medical Center. So it was a merger many, many years ago. So it became the Boston Medical Center. And since then, it actually has also become the Boston Medical Center Health System with very close networks with a lot of community hospitals. And more recently, it started an affiliation with the St. Elizabeth's Medical Center, which is part of the Steward Medical Group. It is a level 1 trauma center, major trauma referral center for New England. It is a safety net hospital. So it is one of the not too many academic medical center safety net hospitals. Has a very multicultural patient population. All of our signs are in Spanish and Haitian Creole. We have a very active Haitian Creole population. This is the Department of Neurosurgery. This was just a picture from 2018. It looks like there's a lot. This is me right here. Looks like there's a lot of people, but this is the chairman, Dr. Holzapfel, our spine attending, Dr. Massingill, and that's actually the only 3 attendings that we had for a couple of years. A little more on that later. So it looks like there's a lot of people in this room, and there are. We do have 3 residents here because we had just started the residency, and a little more on that again later. These 3 residents and the rest are pre-residency fellows and APPs. We currently have 5 attendings. We're looking for a 6th in spine because Dr. Massingill, who was our spine attending, subsequently left. And we have 2 neurosurgery attendings at the St. Elizabeth's Medical Center, one of whom also has a faculty appointment at Boston Medical Center. We have 7 APPs. Between outpatient and inpatient. We have administrative support, and we have a complement of pre-residency fellows. We like to have 8 total. We don't always have 8, but we try to have 8 that are split between the Boston Medical Center and St. Elizabeth's Medical Center neurosurgery departments and the Boston Medical Center neurocritical care. We are a major partner for the Beth Israel Deaconess Medical Center, Harvard Medical School Neurosurgery Residency program. As a little blast from the past, Dr. Alterman is actually the chair of that program. He was one of my attendings when I was a neurosurgery resident at Mount Sinai. I spent a lot of time doing those DBSs when I was at PGY1. The program started in July of 2016 with our inaugural resident. We did not do any backfilling of the residency program. We did take one resident out of the match from a residency program that closed. And so we kind of adopted the one resident. But other than that, it's been a very gradual increase in the resident complement to our to the department. The program is 7 years. They have 1 year protected research time and a 6-month pediatric rotation on Boston Children's. But we are a major partner because truly the neurosurgery residents spend 50% of their time at Boston Medical Center. So we are truly equal in the amount of time that the residents, and the rotations are very carefully designed to make sure that that ratio is kept. I am very excited because in July of 2021, in a few months, we will actually be at a full complement of 7 residents, which is very exciting because then we will have 2 residents at all time at Boston Medical Center, and that will really be huge. So, you know, my clinical development as a neurosurgeon has been really impacted a lot by the staffing levels and the department. So I alluded to a little bit earlier, we had a bit of turbulence in our staffing levels, and with a lot of influx and outflux, and you know, it really resulted in some quite brisk call schedules. So I was about average of Q2 call for 2.5 to 3 years at a level 1 trauma center, which is quite busy. And the residents, again, you know, the residents were coming, but they're very few and far between at the beginning. And the pre-residency fellows, some were fantastic and many became neurosurgery residents, maybe others a little less, but no one comes in knowing neurosurgery. So I spent a lot of time as a chief and an attending. And I have to say, carrying the 2009 pager and being a Sinai chief resident prepared me extraordinarily well for being able to take on that load without losing my mind for so many years. And of course, my silver lining to all this intense call schedule, because, you know, if I wasn't Q2, maybe I was Q3, but it still wasn't all that comfortable, is that I just feel like I accumulated an extraordinary amount of clinical experience, and I feel very old in the clinical sense of the word, as far as the amount of cases I've had to handle and juggle. So I gained, you know, a decade's worth of experience or two just by this during this moment. And of course, the fact we are a safety net hospital, I hadn't quite processed what that meant. That has a lot of implications on the resources that are available. And, you know, I so miss the neuro cluster at Sinai with all our scrub techs who knew everything of what everybody wants, and really were such a resource. And you know, really, you're so lucky. You're so lucky to have such a fantastic team in the operating room, because that can really make all the difference too. And so because of this, I would say I've really spent the majority of my time in the clinical trenches as we speak, and I've enlarged my scope. I have a very wide-ranging case mix, primarily brain and spine, with a smattering of peripheral, of course, a few carpal tunnels and perineal nerve decompressions. And I have to say, I did a pinch of functional light, which just we didn't have a functional attending for a long time. There was a lot of batteries that need to be changed, and some spinal cord stimulators. And even I threw in a revision vagal nerve stimulator because someone just couldn't wait and also had nowhere else to go. So it was very interesting. So in some ways, one of the residents told me, I think it's I was trying to say this is like a general case mix, but maybe complex generalist, because the complexity of the cases was been quite big. So I'm just going to share some few interesting and or controversial cases. I feel like when I was a resident, some of the most interesting talks, at least amongst ourselves, when we went over some cases just to get a little bit more of the juice running, the clinical juice, but I'll just fly through it. We do have a stealth machine, which is a very exciting. For spine, we have a C-arm. So that's about the extent of the technology we used. I always salivate when I see all of Dr. Betterson's phenomenal 3D pictures with everything on them. That would be so amazing to have, but we just do what we can. So this was interesting 57-year-old with a grand tonic-clonic seizure after MVA intact. The question is, so what is that? I don't know if it's going to be hard to have audience participation sometimes in this format versus the in-person one. So I'll just, let you think about it. And I suspect you probably want some other sequences to try and figure it out. And here you go. And still, what do you do? I don't know. Well, it needs to come out. I mean, I think there was someone who you say if it's white, it needs to come out. Well, it's not quite white, but it's big and it still needs to come out. And here we go. So I took it out and it turned out it was a dermoid cyst. And it was very interesting because it was from the sylvian fissure. And it was very attached to the MCA and the ICA, which you could see floating up into the cyst wall. So it was too adherent to fully resect the cyst wall. So of course, I just opened, irrigated a lot. And it's true, there really are teeth, nails, and hair in these things. It's really, really true. And there were cortical flecks of white all over around the cortex. So clearly when he had the MVA, he had a micro rupture of the cyst, which we could see the evidence of. And that's what caused him the seizure. I wanted to take pictures. Unfortunately, they had just enacted a very strict photograph policy, and I had a very strict circulator in the room, and we didn't have the appropriate consent in the chart. And so there we go. This is forever just in my own memory, but it was very interesting case. So just little pearls here of wisdom that I've learned. It's not always a tumor, even though as a neuro-onc more oriented, you always think it's going to be a tumor. It's not always a tumor. And the cortical specs were very, very interesting. This one was a tumor, and 38-year-old, she had a tumor resection a long time ago. She said she had declined Temodar and radiation. So of course we think, oh, it's probably glioblastoma, anaplastic gastro. It turned out to be an atypical extraventricular neurocytoma. So just to show, neurocytoma is not always in the ventricle. It really is also outside the ventricle, although I just took out a very large intraventricular neurocytoma this week. So it does happen to be in the ventricle, but just so we know. And this one's just for Dr. Post, really out there, that can't forget about the pituitaries. And what I learned the most about this case is that access can be a very geopolitical situation, insofar as, the ENT's service has the endoscope. And if you're going to do endoscopic, it's really interesting. So it's not always about your skill set or what you know. There's also a whole geopolitical landscape that can come into play into how you do a case and what approach you use about endoscopic versus microscopic. This was a really interesting case. I think the diagnosis is pretty clear in this. I think I would hope from the residents. But the question is what to do. And this was one of the few cases that I would say there was a lot of third and fourth opinions, which is more what I associate with maybe Manhattan when someone goes, all the different medical centers and gets many opinions. It doesn't happen to us very often, but this one was happening. And so this patient was given some limited options at all the different places in the city. And does everyone know? I'm sure all the residents have guessed what this.
I was just thinking, Emanuela, these are such great cases. Chris or Peter, is it possible to elevate some of the residents so Emanuela can engage them a little more directly? Right now, they can't speak, Emanuela.
Right.
We can-
Yeah, that's how I figured. I was like, okay, well,
No,
I
we
think-
can unmute them. We can unmute them. Hold on a sec. I mean, I don't want to interrupt, but if you have time in your talk to engage them, then we can.
Yeah.
unmute them.
well, at
Yeah.
least a little bit here and there. But this is even, this case caused a huge amount of controversy at our tumor board, even just at the attending level, because
All right, well, let's ask, is it okay if I ask on your behalf? Because I see you
Yeah.
coming up. All right, Alex, what do you think the diagnosis is? Can you give us a differential?
Sure. For optic tract lesion like this, and glioma is definitely high in the differential. I didn't get the full history, but I assume it's otherwise pretty healthy 19-year-old.
Yep.
Yep, not non-syndromic or anything like that.
Yeah.
Okay. Then yeah, I mean, glioma would definitely be at the top of my differential.
Glioma like glioblastoma?
Yes, I would say a higher grade glioma, like a optic apparatus glioma.
Alejandro, you want to give a second opinion?
I was thinking glioma in terms of NF1 as well. I mean, you don't see the sphenoid wing atrophy that you see that can be associated with it as well. But I'm wondering if there's any other features that can point towards NF1.
Halima, any other thoughts here?
I mean, optic glioma and then like optic nerve sheath tumors. Yeah. So,
Optic glioma, okay.
Yeah. Very good.
Mhm.
Yes. So, oh my goodness, my pointer. Oh, well, yes, that's exactly what it is. I'm not sure why I'm not advancing right now. Sorry about that. A little technical glitch. Let me see if I can. Well, yeah, so it is an optic nerve glioma. And so we took her to the OR. And basically, the options she was offered everywhere else was a total tumor resection, orbit exenteration, prosthetic eye. And, this is a 19-year-old who doesn't want a prosthetic eye. She would like to be able to wear her face up and out of her eye. And her main goal was to be able to, wear glasses like she used to and wear her hair up. So we did a subtotal tumor resection with a primary goal of obtaining tissue to see if she had any other chemo options. And we did it with oculoplastics and ENT. So we did orbital wall decompressions, both medial and orbital, and we debulked the tumor just enough so that I took out just enough so that her eyes could be the same. So the oculoplastic surgeon provided a corridor, and then I did the tumor resection. And just so we were able to get a very good cosmetic result and some tissue. And, I think the goal, the pearl here is to listen to the patient's goals of care. This is a 19-year-old, and this was really, she didn't want to go to college. She's now in college and she's doing her thing. And it might not have been the true oncological resection that we think of. And, again, big controversies at tumor board on this, but it was what the patient really needed to have done and what she wanted. And she looks fantastic now, and she's wearing makeup, night and day as far as her outlook on life. And she can still now, it turns out there are no chemo options for her. And so she has to do radiation, but she's a little hesitant. So this is just a few, just rapid fire. The first thing you're thinking, oh, dental abscess, big thing in the head. It's, we think probably it's going to be a abscess, but instead this was the contrast MRI. So, which looks more like what?
Abby?
Yeah, like a meningioma, right?
Oh, okay. Yeah, I
Like,
was gonna
the way I
say,
didn't know if the volume was up or not. So it looks like something and then it's something else. And it turned out it was actually a meningioma. So my little pearl here is the first reaction diagnosis doesn't always pan out. And it took a lot of persistence to get the MRI because first she got it without contrast. there's a lot of pressure. Oh, go to the OR, it's an abscess, and it's an abscess. It was not an abscess. It was just a meningioma. So super important to really get, you know, when you're kind of playing the role as the chief resident and the attending, I mean, you're really at the front lines of all this, sometimes a lot of angst, but it's really important to get all the data before you make a plan. Now, this one is more typical. One is going to see this, a 40-year-old with weakness and blurry vision. This one is not a curveball. It looks like a meningioma. It is a meningioma. The one thing I would say I learned from this case, though, I took her to the OR, of course, atypical meningioma, is the importance of the CTA and CTB, because it was draining into the inferior sagittal sinus, which is quite a challenge. And it was also being fed by the pericallosal. So knowing the blood supply very, very well for these giant meningiomas has actually served me incredibly well on many occasions. So I do now, you know, find that I do that on every meningioma essentially, because there's always something very interesting to learn, because quite frankly, every meningioma I see, it seems, is giant. I think that's possibly related to my practice environment. People don't go to the hospital or get a scan if they just have a headache. They come when they're weak or seizing. And if in the few times I've had a small meningioma, the patient was a giant, and they, you know, like BMI of 50. So it never worked. It just never works. It's like something's always giant. It's always a huge, huge production. So it's either like 0 or 100 for meningiomas. Nothing, or you don't see them, or you see something big. I couldn't help but putting a little vascular case in here, just, you know, in honor of the big vascular presence that I had when I was a case. So this is a 30-year-old. She had been discharged from another hospital with a temporal hemorrhage that had been stable. She had worsening headaches and some aphasia. We presented here and we see the scan. And of course, you're going to say, oh, maybe, and they had done all the work of the other hospital. We just did it again because they must have missed something. So we redid the MRI and the DSA. No AVM, no aneurysm that could be seen. At the same time, she's progressively getting worse. She has a tight brain. She's still okay. She's just aphasic and headache, but it wasn't going in the right direction. But any thoughts on what this is going to be? Any ideas? Huh?
Who was speaking? Someone speak up.
Potentially a cavernoma.
That's it. And it's really fantastic. You guessed it right away, because we actually got a pathology that confirmed the presence of a cavernoma. But for some reason at our hospital, it was a large hemorrhage, and everyone's saying, oh, it's a large hemorrhage. It's probably not a cavernoma because it's too large for a cavernoma hemorrhage. But it turns out that's just a faulty line of thinking, because it can definitely be a cavernoma. So, and this is going to be my last cranial case, because again, just a little bit of a 30-year-old with weakness. And, you know, Dr. Binello, I have this patient, 30-year-old, she has weakness. She has this lesion in the medulla. And of course, you know, it was a very beginning fellow. And so I thought, oh, he must mean intramedullary in the spine. Maybe he doesn't really know what he's talking about. It turns out he did. And so what are the two top things on the differentials here?
Let's call on Matt. Matt Carr.
It's a pilocytic.
Good. And what else?
Posterior fossa, medulla.
Yeah. Any other takers?
Or hemangioblastoma, I guess, given that sort of cystic.
That's it. Perfect. It was a hemangioblastoma being fed by the pica. So, but sometimes, honestly, the smallest lesions can cause the greatest angst when you're in the brainstem. But the approach was, you know, I thought about it in a very simplistic terms. It's almost like a Chiari that you can just do it, open up there, and then you lift the tonsil up, and you were essentially right there. So the patient did well. So that's my little smattering of cranial cases. I have a few more for spine. All these were done with a C-arm. We just got acquired an O-arm about a month or two ago. I haven't used it yet. And then, so this is a 62-year-old with weakness and spasticity, lung nodule, smoker. What do you think?
Trevor?
Well, there are two big things that come up. One, you think smoker, lung nodule met, or maybe
It looks like it could be a ependymoma.
sure, or anything else. Yeah, this was a little curveball. It turned out to be an atypical meninge. There we go. And the reason why this is important, though, because the steroids are very different between a MET and or epidural spinal cord compression versus a meningioma. So if you really think it's one, you can stick to your guns. But there's a lot of, there's always a lot of discussion involved in some of these. Now, I have a couple of spine trauma cases, because it turns out when you go to a lot of these conferences and you talk about spine trauma, I was always thinking, oh, hemicranie, subdural, and so forth. Well, there's a whole world of spine trauma that is there. And as the Tegi call it, a level 1 spine trauma center, you have to do spine trauma and cranial trauma. And so all of a sudden, I was really thrust into having to do with a lot of spine trauma. So this is a chronic C2 fracture dislocation. He had fell 3 to 6 months ago, but he was surprisingly fully intact with minimal pain. So first, drag your feet a little bit, hypercalcemia, they diagnosed him with sarcoid, but then eventually this has to get fixed. And, the big question here is to reduce or not to reduce. So I ended up doing just the OC fusion with minimal reduction. I tried a little bit, but if the patient's intact without long track signs and in minimal pain, there's a lot of risk involved to reducing. And so in this case, I opted to minimally. I just did a smidge, but not too much, and the patient did fine. So it turns out you can defer reduction, but it's sometimes you can't. And I'll have one more case of really interesting where you really had to reduce. But the other thing is I've learned a lot about burst fractures. And I have to say about, the anterior versus posterior approach, front, back. I've somehow gotten through all of these various scenarios. And I'm just, in the interest of time, I'll just try to give you a little bit of the things I've learned is that when you do have a tall and thin neck, it is possible to reach down to T1 anteriorly. It really depends on the patient. This was a C7 burst fracture, clearly needed a ventral decompression because posterior wasn't going to do too much. And it's possible to do it, but it's not easy, but it's possible when needed. However, the biggest difference is whether or not they're going to have a trach and the level of injury. So for example, this was a C7T1 subluxation. And so the question would be, do you do a front only? Do you do a back, front, back? And in this case, I decided to do a front and a back. But I have learned a few things that if one is trying to do both, better to do them in the same setting, because when you stage them, bad things happen in between that can really prevent you from progressing to the second stage. And if you were going to do one first, it's actually better to do the posterior rather than the anterior, because it's always sometimes trickier to prone people, especially in the setting of spinal shock and bradycardia. And the other last thing is sometimes you think you're going to do a front back and you see a trach in the way, and it turns out that maybe the anterior approach isn't great because of the trach that interferes and it's infected, and then you're going to have other problems. So sometimes I try to err on the side of the posterior approach only. And these are all just very practical considerations, hospital specific, at least for my hospital, and what is able to get away with stabilization with minimal complications. And so in this case, with this burst fracture, I decided he was going to have a trach. I didn't want to go anteriorly. So I was just trying, and he was already complete. So as you can guess, what I decided to do is just go posteriorly, but I still wanted to provide some ventral decompression. So I ended up just trying to do the transpedicular ventral decompression, which usually we do for the lumbar spine or thoracic, I've heard of more than in the cervical spine, but you can extend the concept if you're really trying to avoid the anterior approach, but still trying to provide some decompression. So these are a lot of just very basic practical tips that do. This one was a different case. And I do want some audience participation in the next one. I'm just gonna leave this one last one as a simple, this was a 69-year-old, we had two things going on, abscess and fracture. And because he had an external fixation that was fixed. So in this case, you know, there really is not a lot of anterior column support. One would think an anterior cage would be a good idea, but in the setting of an abscess, I opted to just keep it simple and just do posterior screws and call it a day because it was going to be too much. Now, one of my last cases was this. So this was a 34-year-old who had been in an accident. She was pedestrian struck, then she ran up on a roof, and then she jumped from the roof. And she is actually surprisingly intact. So, and we have a scan here. And so what are we going to do about it? So this one, do any residents have an idea what kind of approach you're going to do?
Travis, you have any thoughts on this?
Certainly a challenging one. You have vertebral body fractures at 3, 4.
2, 3. But yeah.
It's 2, 3.
Yeah.
Spine slipped. Oh man. Okay, I think you could do it. You could do it prone.
Mm-hmm.
And decompress.
Mm-hmm.
If she's intact, I'm not sure what the gain is to try to restore that alignment. Looks like vertebral bodies are like adjacent to each other, right?
Yeah, so it's like a spondyloptosis, right? So it's like lateral spondyloptosis. The vertebral bodies are next to each other. But I did find there to be some benefit to reduction because this lady wants to walk subsequently. So I did think you needed to restore the alignment because in order to handle the axial loading. And while it might seem like something like this would never be able to be reduced, I had a very profound observation during this case that it's actually less force than expected to reduce the spondyloptosis because the ligaments of the facets are fully disrupted. So it turns out if you do manual traction, but then apply downward pressure, and because the posterior elements are still connected to the vertebral body in this case and twist a little bit, you can actually restore the alignment. So it's really a question that you need to pull, exert force a little bit this way and then a little bit down, and then you're able to restore the alignment. And you need to restore the alignment before you fix it in place, or you can try to restore the alignment also a little bit with the screws. And the other really profound truth I learned, which is probably something very common in deformity surgery, but I didn't do a deformity, I was really more about brain tumors, is that the order of the rod placement can facilitate reduction in the coronal plane. So if you put the rods on one side first, it can help pull this over to the other side and stabilize it more. So I just had these two very profound realizations during this case that I just had to share. It's not as hard as one might think, but it is a challenging case. And just these are more vanilla things. The only thing to say is hybrid MIS. I'm really getting into MIS techniques, minimally invasive techniques, and they're really great because you can do a lot of less muscle dissection, but still decompress where you need. And I've tried to get away from cages and really push the envelope of what we can do without cages and avoid corpectomies. It's not cages like ACDF cages, but like big corpectomies. And the last thing is MIS, minimally invasive techniques I really use them a lot. And you can really get great reduction, even in grade 2 spondylolisthesis, but you may need to do bilateral facetectomies to restore alignment. And that is, and you can really get very large, spine surgeons are very much into how big of a cage you can get, and you can get very large footprint cages, even posterolateral with a wide enough facet decompression. So, and at the same time, when you have a revision here, I just found these little annex tubes that make it much simpler to just extend for adjacent level disease rather than having to redissect everything and take it out. So I'm just trying to do the as little as, trying to get the best bang for the buck. So I would say one thing, neurosurgery residency is really foundational and will profoundly impact everything you do. Most of my trainees know Dr. Betterson's preferences, the low profile on the stealth. They all know about magic with Dr. Post. They all know about it's just one of those things, you carry your training with you. And there is, though, a very delicate balance between complication avoidance and expanding your clinical repertoire while you're growing in scope. And that's an art in and of itself, because there's some things, I was in a unique position that these things, the cases needed to get done, and I was there to do them. But it may or may not be feasible, likely in other type of practice settings, but it's a really careful balance. And I sometimes have to I'm mentoring some of our younger faculty who think, oh, we need to do a 2-level corpectomy and up and down. I was like, well, maybe let's slow the horse down a little bit and let's think practically what we need to do here. And it is true. I used to hear this phrase when I was a resident, your patients are your calling card. I think that Dr. Jenkins would say that, and I've learned some truth to that. So, the bulk of my activities have been clinically in the trenches and a very grueling call schedule. But it has given me, of course, a lot of opportunity for clinical mentoring and teaching, especially to the pre-residency fellows. We have had 7 placed into neurosurgery residency programs, and I've personally had a hand in 6 of those 7 who have gone on. And I have done, despite the schooling, I did create some time, and I served on the FDA a few times on the Neuro-Oncology grant panel, just to at least keep track of what other people have been doing, although I haven't been doing so much myself in that particular area. I've taken on an enormous number of administrative tasks. I don't think anyone would be surprised when you meet in residency that I'm the master scheduler. I continue making all the call schedules, just like I did when I was a resident. I am now doing it when I was attending. And now I used to just do it for the attending. And now I even do it for the fellows, the house staffs, the APPs, because we need the master circuit integrator. And it turns out that I've taken on the role of the master circuit integrator. But I also took advantage of some bit of lapse in the administrative direction with the going out of the old and coming in of the new. And I've really gone into the ambulatory world and rearranged the outpatient clinic and made pods and redid the referrals and the referral workflows and phone communications. And I got on to all sorts of metrics so that we're now like one of the best performing, phone answering departments with the shortest amount of scheduling for referrals. I've just really had a huge hand in the administrative world too. It's not as interesting as the clinical, but it can make such a difference in our quality of life when the clinic is functioning well, that I've now expanded my scope into the administrative arena. I have done a little research. I did finally finish up the paper that I did with Dr. Germano, and I'm very proud to show that the cover of the Journal of Neuro-Oncology actually had the figure from our paper in it. So the April cover of that, the cover was pretty exciting. And we've got some databases going on for trauma outcomes. We're doing some outcomes research, of course. Now, I did put a little thing here about historical, because I had a summer student who was really interested in doing a little thing, and she did this thing on paper on trepanation in ancient China, and it just took off because Smithsonian Magazine picked it up, Science Magazine, and now I get requests to review archaeological papers. It just snowballed into something outrageous, which I never expected, and got way more publicity than anything I've ever done in the scientific world. Forget about all those molecules. It's the trepanation in ancient China that got me noticed in the world. So in closing, I just have a few words of wisdom as things of what I've learned. And I say this in practice. I've spent a lot of time interviewing spine fellows and candidates because we want to hire. So I always say it's great to have a great job interview, but choosing a job is really a multi-parameter optimization based on location, practice environment, and of course, compensation plans. And those are the three things that everyone starting out asks me about. Then you have mid-level surgeons, and you can tell because they start asking me about the last two things, and they are more concerned about institutional resources, the practice leadership, which are also very interesting. But it's very interesting because these last two questions are only ever asked by mid-level surgeons versus the other ones. Just for starting out, it's good to choose a conservative approach to cases because you do, again, it's that balance between growing and doing big cases, but avoiding complications. And there's this thing called coding, which to be honest, I fully missed the memo on this when I was a resident, and I had no idea. And after my first few cases, they're like, what do you want to submit for codes? And I'm like, what codes? What are you talking about? Well, it turns out every case can be described by CPT codes. CPT codes are assigned these things called RVUs, and those make a difference in your salary because often there's dollar amounts that goes to RVUs. And these are 3 books that I finally found to be very, very useful because we have to do our own coding. And this is just an example of the coding. There's a whole new language. I'm not going to go into the details, but just to show you, there's like a language of numbers that can describe the cases you do. And these are kind of examples, and it's very important to know this. And when you thought that was it, there's even modifiers now to even go along with that. So good to know. And settling in, it's never too early to start preparing for the boards. You have fantastic resources. I really encourage everyone to take these 2 courses. They're very good. They're very helpful. There's nuances to choosing your specialty, subspecialty area. And you really should do it and focus on that. And my concluding remarks, some words of wisdom for the current residents. There are some, and I with maybe some of our younger faculty members, there is sometimes an idea, well, I'm going to be the vascular person. I'm never going to have to do spine, or I'm going to be the brain tumor person. But you never know. Sometimes you will need to stay broad. And so it's good. I would recommend while you're a resident to at least keep your interest level broad and learn everything you can from all your attendings, because you will be using it. You never know how much you will use it. And a solid clinical foundation will also give you more bandwidth to absorb all the administrative or business aspects of being a practicing neurosurgeon. Because if you're too stressed clinically, you're not going to figure out how to do the codes. So it'll help you. I do have to say my most sincere gratitude to everyone who have played a role in my neurosurgical development, who gave me the opportunity to become a neurosurgeon, who trained me. I always keep my, especially at the beginning, but even still now, I think, oh, what would someone do? What would someone else do? And I do look forward to connecting and or collaborating with anyone from Sinai in the future. And I just thank you for your attention. And here's my contact information. And I'm all set. Thank you.
This was amazing. It's above and beyond anything that I could have even thought, although I knew some of this trickling down over the calls and so on and so forth. When I introduced you, I tried to give a sense that you're a modern day Renaissance woman with your background in humanities, Russian literature, speaking many languages, and then your nuclear engineering and so on and so forth. But I think the talk that you gave really shows that you are a modern day Renaissance neurosurgeon. And this is very, very unique and very rare. So I would like to ask, what do you think, if any? I know that there are a lot of different things, but if you had to pick one pearl, and I really like that picture of the pearl, that allowed you to be so broad and so comprehensive, what would that be?
Well, I think there is, my breath came out of necessity. So that was really, there's the mother, necessity breeds. There's some phrase about necessity and the mother of invention or whatever. But what got me through is you just taking a stepwise kind of logical, I'm not going to say engineering approach, but just to kind of think through what needs to be done, and really just the basics of good, just surgical technique that you can expand to many areas, and just to be patient and just to forge on. So I guess it's just going back to the fundamentals, the fundamental surgical techniques, and then expand on those really is all you can say, because nothing will ever prepare you for every single scenario that you might see. So you have to just have a very solid foundation, which is what I was trying to allude to. So I do think that solid foundation comes from residency.
Emanuela, you just blew me away. You just blew me away.
So here we go. So it's just been quite the journey. Maybe not quite what I had expected when I graduated, but this is where we are, and there's still time, there's still more things to do in the future, and hopefully we'll take a little less call. But as an aside, not that I don't mind being faced with all of these hard cases constantly and barrage, but it'd be nice to maybe have a little more time to focus and maybe do a little more research for the future.
Emanuela, thank you so much for coming to spend your time with us this morning. Fantastic talk. This is the 75th anniversary of our residency. And I think one of the things that you highlighted, which was an experience that I had too, is that sometimes in life, you think you're going to be one type of neurosurgeon and you learn to adapt and change to the job and the market and the city and everything else. Can you talk for 1 minute about how you continued to develop those skills so that, I know you were a brain tumor focused person. Did you do additional coursework? Did you work with different people? Like, how did you do that so you could navigate and manage through?
So I did spend, when I first joined the department, I did spend probably 6 to 9 months scrubbing in with our spine attending, just to get myself more into the go, so that for knowing how to do the C-arm and even our own the specific instrumentation that we have, and I did do a lot of cadaver courses on my own at the beginning, especially for the pedicle screw insertion and using the C-arm. It wasn't all that obvious. And then it's just kind of just abstracting down, and rather than think through the whole thing, just think of the cases and some steps. Well, what do I need? I need to get 4 pedicle screws in, and I need to figure out how to do that. And then you put the rods, and then you have to figure out what order to put the rod, and then just summarize it. But I think the cadaver courses helped. I read a lot, I studied, and then, you figure it out and you make it happen.
Comments from the chief residents. I hope you guys can recognize what you just heard.
Yeah, this was it. Can you hear me, first of all?
Oh, yes.
Okay, great. Thanks, Emanuel. This was a humbling and profoundly inspiring talk. So thank you. I suspect your engineering gives you an advantage in the biomechanics of that spine work. But that said, you made me grateful for the training I've gotten here, and very excited about this trauma fellowship I'm going into at UCSF. My question for you is, what would you say was the biggest challenge you faced in your transition from being a resident to being an attending, and how did you overcome that challenge?
Well, the biggest challenge is to make those plans and carry them out, really, in the sense that, when you're a resident, you get the data, you formulate a plan, but then you always have that person, saying yes to this plan, no to that plan. So it's really, all of a sudden you're the plan, and you have to make it fully happen and take the responsibility for it at the end. And sometimes it's hard because, you might you're not Dr. Betterson right away when you start out. You know, you have to, or Dr. Germano or Dr. Post, you know, or Dr. Srivastava or Dr. Hudd, whoever it is. I mean, there is a learning curve, right? I mean, you have to be able to take an approach that you can complete on your own and make sure you start and you finish. And then you can evolve into doing fancier and fancier things. So I think it's just a realization, a good self-awareness of what you think you can accomplish to what you can really accomplish. And because at the end of the day, in that moment, you know, especially I mean, many of my cases I did with medical students sometimes, who are going into internal medicine, or maybe pre-residency fellows who may or may not even become neurosurgeons. It's a different level of assistance than if I had a PGY6 neurosurgery resident, right? So there's also that element you have to factor into a little bit. So it's just again, multi-parameter consideration and just trying to be cautious and be safe, but continue advancing. And it's just realizing it's really all about you then. I mean, that's your name on that case request. And at the end of the day, it's your responsibility. There's no, it's this, it's that. At the end of the day, you just have to make it happen. And, you know, we do have a very multicultural patient population. And that has had also, and not that I'm saying that all patients should the best outcome, but many of these patients don't have resources for rehab. So you can't be like, oh, whatever, they'll get better during rehab. No, they're going to get better in the hospital, and you're going to watch them, and you're going to watch your complication for many, many months until they're good enough to go home or somewhere to dispose. So, you know, in some ways, the surgeries have to be even the best outcomes because the people have the least resources to help them post-op. So it's something just to think about the whole picture, and it just step by step and just doing the best you can. But it's scary. I tell you, the first few times I had to do those cases, I was like, what do you want me to do with this? And then I was like, oh, I have to do something. Okay, well, what do I do? Okay, well, then let me think about it. And then you just kind of get, so now the jolts are less with time. But I think everyone's going to have a bit of a jolt at the beginning.
Yeah, Manuela, really enjoyed your talk. Great seeing you again. This is Kostas Hadjipanayas. So, hey, how are you? So I think, you know, one of the things that you highlighted, which is so important for our residents, is how you were adaptable early in your career. But now you've kind of found a little bit of focus, right? You're now focusing your career and you find things that you're liking and you're doing well at. Can you just briefly comment on that? Because I think that's an important point as well. You were adaptable for your department, and now you're focusing your efforts on things that you think will help you.
Yeah, I mean, you know, I had to adapt. Again, I had to adapt to the needs of the situation. So I do hope, though, as we get more faculty members, I'm taking a little less call, that I can't. I mean, you know, my first true love was still brain tumor surgery. I would like to do more, and I'm hoping, you know, I really enjoyed the talk you gave at our grand rounds. I mean, wouldn't it be great to have some kind of 5A? I mean, it would be great to try to do a little more, but it's a bit of a challenge when you're in a very resource strapped hospital. But you know, I would like to try to get a little bit more into more research oriented, and you know, I'd like to do a little bit more, obviously, on that. I just haven't had much bandwidth with all this going on, but I'm hoping I'd like to, you know, I just see this as hopefully as this super clinical phase gets to a little bit less intense, maybe I can incorporate, and maybe also administrative changes I've brought can now just kind of settle in. I can, you know, now the wave for the research will be a little bit higher. So I would love to. I was all fired up about photodynamic therapy as an aside, because I think that's fantastic. I'm really excited because it seems like boron neutron capture therapy that I worked on many, many years ago. So I was like, oh, similar thing, let's do it. So I still would like to do that. And I think also now that I'm also learned a little more, some of these cases take a little bit less of my prep work, right? Like at the beginning, I had to study more the pedicle screws in the lab. You know, taking on these cases was like a big investment of my intellectual effort. Now it's still important and invest, but it's a little bit less as I've learned more of the techniques, so I can now have also a little bit more intellectual space to do that. Because you never, it was a learning, you can keep growing and expanding after residency. You won't necessarily learn every single thing. I mean, there's more to learn.
Manuel, it's 9, so we're going to have to move.
Sure.
I'm sure that we could stay listening to your wisdom for hours and hours and hours. What I'm thinking as I hear you talk is two of the characteristics that I remember about you and I see so beautifully done now. Your breadth, the breadth of your curiosity seems to know no bounds. Neutron capture therapy and pedicle screw fixation don't usually get discussed in the same talk by the same person. And that's just a 100th of what you have done. So I think that your intellect clearly has a huge part to play in what you're able to do, and just your candle power, but also your patience. You're a very patient person, and for some reason you want to make things better. Who knows why? Right? Who knows why? But you seem to want to make your environment better, and combining all those together must have led you to where you are. You've humbled all of us today, and we really appreciate your being with us. We'd love to have you back.
Well, it's my pleasure, and I really am sincere when I say I would love to keep in touch and interact more. I do have a little more bandwidth now that we are a little more stably staffed, so that would really be very happy to do so.
Okay. Thanks again. Thanks, everyone.
Very good. Thank you.